Hi, my name is Jaco Rossouw. I'm a clinical psychologist and from South Africa, and I'm affiliated to the Department of Psychiatry at Stellenbosch University. I'm also on the IEPA subcommittee, and our mission is to provide information and training opportunities to members. So today's interview, we focus on the important role of people with lived experience in mental health and specifically in early intervention and prevention. So to talk on the topic today, we have Shannon Pagdon, who is VP of Lived Experience Research within IEPA, and she's also affiliated to the University of Pittsburgh as a PhD student. So let's start with a question to lay the foundation for our talk today. And let me ask you, what is lived experience and your own journey being involved in this field?
Yeah, I think lived experience can represent a number of identities and experiences for folks, whether that's kind of your own background and experiences in a mental health context. It's often kind of similar experiences that you've had to somebody else. I do a lot of work with folks experiencing psychosis and talk a lot about kind of my own experiences navigating psychosis at different aspects of my life. But I would say, it can operate in really a number of different contexts. And I got involved in this work, I would say, over time. I started as a peer supporter and found often barriers to kind of being able to support people in more of a structural or policy capacity. And a lot of the challenges that folks were experiencing who I would work with, just it wasn't entirely their mental health, right? There were kind of other aspects of their experience that were challenging. And that was what originally drew me to research, as well as just finding these kinds of limits or things that I thought were important, including peer support, that just didn't have a lot of kind of scientific literature behind them. So that was really what drew me in the first place to the space.
Right. And I'm thinking in terms of people who work in this space, I think it's so important that lived experience is made part of every aspect of the development of interventions and the development of research. So I was wondering, what would you say are the unique contributions that people with lived experience can make to such a team, and why it would be important for people with lived experience to be included in research teams, in implementation, and also in policy making?
I think it's pretty endless, kind of the benefits and perspectives that it can bring. I think in kind of different on a personal level for folks with lived experience, I know for myself it can really support kind of self-stigma to speak about your own story and feel like it's more normalized for yourself.
Yeah.
But I think that there's also, in something like peer support, there's a lot of reciprocity. You kind of get a lot by giving a lot.
Right.
But in more kind of, capacities in research or in policy, I think that it's just very difficult to understand certain things without kind of directly having gone through certain services.
Right.
And so folks with lived experience can really bring that kind of unique perspective on things. And I think also, like so many other folks, right, we're holding multiple hats. I mean, as a doctoral student and also somebody with lived experience and, somebody who's kind of a master's student. So I think that there's all of these different aspects of identity that we're all holding in a way that becomes really powerful to intersect. And I would say, yeah, that lived experience is just a very crucial perspective. And I guess when we do meaningful co-production in something like research, I think it just completely changes the shape of the research, as opposed to bringing somebody in at the end to just consult on something that's kind of already existing. If you have folks involved from the beginning, I think it just really shapes things in a different way. Even as somebody with lived experience, when I work with other individuals who have that experience, we all kind of are bringing our own lenses, and I think it makes everything a lot more powerful. So ideally, I would love to kind of see us move in more of a direction of having multiple people, because I think that kind of difference of experience is something that can really impact research policy kind of services in a positive way.
Right, right. And I was also thinking, because we get many sort of different ways in which communities can be marginalized. So if you think in terms of people with lived experience, that's one kind of community that's sort of vital to service provision to be included. But there are also other people that might be also excluded based on multiple sort of stigmas, or they are like underrepresented communities. So how would you say that would speak to how people should tackle research and implementation?
I think it's a great question. It's something that I've actually talked about in a peer support capacity in a lot, is kind of how one person is never going to be able to be a good identity match for everybody, whether that's kind of race or gender or your own experiences of mental health. So I think that, and again, the kind of multiple perspectives, I think, even somebody who experiences psychosis, it's going to look completely different from one person to the next. And so having the kind of pluralistic perspectives of multiple people, I think, will just inherently make things more powerful and kind of better matches to the different communities and different kind of aspects of identity that people are holding.
Right. And so, as someone with lived experience, what would you say are the areas of service provision that providers of care should pay more attention to?
I think a very important one as far as direct service goes is really listening and deferring to the person as far as their own personal experience goes. And I sometimes in my own service experiences have kind of experienced folks telling you how to feel about something, or that, for example, like voice hearing should be very distressing, when, not all of the voices I hear are distressing. And so I think when you're kind of told how to feel about your own experiences or what they must be like, that can be kind of challenging to navigate. So really deferring to the person as far as what they're describing, what it means to them. I actually would love to kind of see more talking about meaning of experiences, especially with psychosis, since that is kind of my area of interest. But I think that we really shut down conversations a lot as far as, what it can mean to people to kind of have those experiences and navigate them. But in a kind of more structural sense, I would love to see just greater representation of lived experience across all aspects of kind of leadership policy. I think often, there's very, very limited career ladders for people. And those that do exist tend to be, even in peer support, it's one peer trainer position for the entire state, maybe two. But then, there's not a lot of turnover in those positions, right? Because the person is very happy to be there. And so I think that just really making it more of a pipeline and kind of having more different types of lived experience roles, I think, especially in the States, it's just enormously lacking in a lot of ways, really having, pipelines for peers to kind of work in policy or research or as trainers, but not having to leave the role because they can't afford to live. So I think that would just be a really powerful way of kind of influencing services on more of a structural level.
Right. I want to connect to something you said in terms of really listening to the individual. So I think where in service provision, people have a very good idea of what kind of services are needed as providers, but to remain careful to be person-centered, to be very much, I know the things I can do to help you, but let me also hear you more clearly rather than just to offer the help that I know will be helpful, but also hearing the person more clearly and properly and trying to understand the person individually.
Yeah.
That's really important.
Yeah, I completely agree. And I think also to that point, really offering the person what they're asking for. I know, for again, for myself, a lot of the kind of ways of learning to navigate voice hearing or, like my experiences of psychosis without medication, which wasn't effective, were things I learned outside of the system because I didn't have a therapist who would kind of sit with me and say, how can we think about that? How can we work on that? And I think it would, especially, with the kind of focus on early intervention and psychosis, I think really supporting people and kind of learning what they want from, their treatment, and really kind of listening to them in a person-centered way on, okay, let's, we can work on medication if you'd like, but also what other things, can we kind of provide you with? So I think it's often very empowering to kind of feel like things are more in your control.
So I'm also thinking from a South African or an African setting, in terms of policy development, and particularly in terms of early intervention. I think we're speaking in general sense of mental health provision, but if we speak specifically to early intervention, early intervention is really difficult in environments where healthcare provision is constrained. So in the USA, in terms of early intervention, where do you see there are areas that the system that you've been exposed to need to continue to improve to help people? What would be needed to help people to come into contact with the mental health system quicker?
That's a great question. One area I'm definitely very passionate about is access to services in rural areas. As somebody who grew up in a rural area,
Right.
and I missed kind of access to coordinated specialty care services by a very short period of time, I think maybe a year or two, but there was nothing there. I mean, it was just essentially one psychiatrist in the community at the time and a couple of therapists. And I think I experienced great kind of self-public and structural stigma after I was kind of first experiencing psychosis. And I think that does just make you kind of want to isolate and not disclose your experiences. So I do think that that's such a big one, is just I think about this a lot, that kind of very much in the States, especially since COVID-19, I think there's been a lot of conversations around mental health and just the importance of kind of talking about it. But personally, I haven't seen a lot of that extend to experiences that are much more stigmatized, like psychosis.
Right.
And if anything, I actually think we're kind of moving in the opposite direction of late, of really kind of much more greatly stigmatizing these experiences and kind of what it requires to get people into care initially, which is very often kind of hospitalization and mandated treatment. And I think if we really did just kind of speak to people more and open the door for them to talk, I think we would have great success with really kind of that more person-centered approach. But I mean, I guess like on a larger level, I think that coordinated specialty care is great for what it is, but it's often very limited in kind of who can access it, as well as, I mean, limitations of billing, or even kind of who is allowed to be in the kind of conditions for entry into CSC, because when I moved out from California to New York, I was just over 2 years post diagnosis of schizophrenia, and I did not qualify for CSC. And I was still very early on into my own experiences, right? But I think that that very strict kind of criteria is enormously limiting. And the other reason I say that is because there is nothing after CSC, at least in the United States. It's super rare to even, have a kind of step down program that's willing to treat people after the 2 years typically of CSC. And it is very, very hard to find outpatient providers who are willing to work with individuals experiencing schizophrenia for a number of reasons, whether it's kind of the providers. I personally experienced kind of the great spectrum of, oh, you're too high functioning to have been diagnosed with schizophrenia, or you just need to go back on antipsychotics because, you're still hearing voices, or just, I don't work with anybody experiencing that. It's too severe. And I think that that not only kind of reinforces the stigma and lack of wanting to disclose, but I think it also just speaks to a greater need, certainly in the States. I think it's an enormous need of greater access to services for folks who are kind of in ongoing care. And I think often the benefits of CSC won't necessarily last when you go from this very structured kind of wraparound model straight into this kind of very sobering outpatient type treatment. I mean, I just, can't imagine that kind of the benefits would continue to sustain. So I think that really providing folks with a greater access to kind of early intervention type services, but for a much longer period of time, would be something that I would love to personally see.
Right. And I think also you speak to the importance of education.
Mm-hmm.
So community education, community-based education, education in schools about mental health. But I guess also one has to go and look at the training of providers and look at how early intervention can be inserted into training of providers and also people with lived experience being part possibly of providing training at university level. I think if more providers are more exposed to people with lived experience as part of their training, that could also be a huge step up and hopefully provide for less stigmatizing experiences for people who are in need of care.
I completely agree. And I think that I would love to see education for providers actually around peer support as well. And I think just preparing teams for even hiring peer supporters and kind of how to navigate that. But, as well as kind of the education piece, I'm super passionate actually about mental health in schools as somebody who had just two extremely kind of traumatic experiences in higher education as far as experiencing psychosis on campus and how that was kind of handled on both a high school and college level. And I think that it is we could do so much better as far as that goes. And I think that it starts with education, certainly. But I think also just, really providing support. I mean, I think all the time also about accommodations and just working with people on that and having kind of a greater understanding of accommodations for psychiatric disabilities such as psychosis. I think it's a really big area of need.
The more we speak, the more I realize the importance of advocacy in terms of also access people who make policies, because the policy process happens a lot of the time very far away from the providing of services. So I can see that we could carry on for a very, very long time talking further, because it's a very, very important topic and something that needs to be spoken about a lot more. But we will have to end there for today. So Shannon, thank you very much.
Thank you.
For speaking to us about this really important topic of people with lived experience. And we will continue to work together. Thank you.
Thank you.